Welcome. This is the long-awaited, much-anticipated Learning Plan 5, Achieving Quality Care. I know you've been waiting for this lesson plan. This incredible set of lectures is going to be just the high point of your summer. I guarantee it. Only if you have a really horrible summer. But this is very important information. It is relatively dry. I'll be the first to admit it. But it is critically important to understand evidence-based practice and why nurses need to follow evidence rather than habit, rather than we've always done it this way, rather than it just makes more sense this way. Because I would imagine that in your time in clinicals, you've noticed nurses do things that you know are not really according to best practices. They're just what they always do. So I want to teach you, I want to explain to you, I want you to understand why evidence is very important, why nurses need to get more comfortable researching evidence and finding evidence and then presenting that evidence to their peers. That will be an uphill battle, but you will find people. You will find one person, and then two people, and then four people. And pretty soon, you can implement a change that goes system-wide. I'm going to give you an example in just a few moments, okay? So just bear with me. Believe me when I say that in this learning plan, we're going to cover quality indicators. What are the outcomes we want? What is evidence-based practice? What is continuous quality improvement. Actually, there's a lot of different acronyms for that. We touched on that recently in a previous learning plan. How to make changes. What's the change cycle? And that came from Learning Plan 2 that we talked about already. We're going to talk about sentinel events and the use of near misses and why a near miss is as critical to make note of as an actual error. But let's talk about briefly why this is so important. The Institute of Medicine issues its state of quality of healthcare on a regular basis. And performance, it always is variable. It varies based on location within the country, based on the socioeconomic status. It's based on many variables. The healthcare system is fragmented. It's poorly organized, and it doesn't make the best use of resources. An example, Green Bay, a town of 100,000 people, has 4 hospitals. It has 12 MRI machines, and they're not always in use. I had my knee done with an MRI. I was the only patient that entire day for the 2 MRI machines in that building. So we're not making the best use of our resources. We have too much supply, not enough demand. There's more chronic illnesses now, more heart disease, diabetes, obesity, smoking, arthritis, cancers. There's just more of these chronic illnesses that really has a big impact on the system. And the system is really confusing. It's complex for everybody. When was the last time you looked at your bill from your insurance company or your hospital or your clinic? Do you understand everything you were charged for? I used to work for an insurance company. I used to create some of those documents, and I have a hard time understanding those. I created those, and I still can't understand them. They do that on purpose, not necessarily to hide incorrect things, but to kind of keep people off balance. If you're kind of off balance, you're less likely to really ask questions because you don't know what question to ask. Now, the Obama healthcare legislation will eventually maybe create a more unified system. That would be great. I'm not going to hold my breath because that is a major task, but that is the goal. So in evidence-based practice, what can you do? You, as a single nurse, what can you do? Not much, right? Or Can you? I want to give you an example. I mentioned the Institute of Medicine, and they give their quality of care reports. And they noticed that there was a healthcare crisis beginning in 1999 and ongoing into 2004 and 5. They found that 44 to 100,000 patients died annually in hospitals every year due to error. 100,000 people a year due to error. Medical error, in 2004, medical error was the 8th leading cause of death in the U.S. 8th leading cause of death was mistakes. Not necessarily malpractice, just mistakes. How would you feel about that? How would you like to know that you go to the hospital and you have a 1 to 5% chance of dying from whatever's going on? Not good. So the Institute of Healthcare Improvement, IHI, realized that there was a major problem. The CEO, it was a doctor named Donald Berwick. Donald Berwick, his name is not going to be on any test, but I want you to understand what he did. He realized that there were some major fundamental problems. People were not using evidence. They were acting on habit. An example, he found that in 2004 and 5, 1 in 10 patients did not receive antibiotics at the correct time after surgery. 10%. Would you find a 10% error rate acceptable if you were one of those 10%? In essence, that would be you making a med error 1 out of every 10 med passes. How long would you stay in your program if that were the case? Probably not very long. But at the time, that was considered the standard. 1 in 10 errors. At the same time, Toyota, the car manufacturer, had a tolerance of less than 1 in 1,000 for their error rate. On their manufacturing line, if they developed a problem more than 1 in 1,000, they shut the line down to figure out what was going on. 1 in 1,000 for cars, 10% for humans. I have a problem with that. So he discovered some best practices that were not being used on a regular basis. They were being used in some places, but not consistently. And consistency is what drives long-term success. He only had a staff of 75 people for his entire office. That's pretty small. He was addressing a convention of hospital administrators in December 2005, and he presented his plan. He set a very specific goal. He said that in 18 months, he wants to introduce new practices that will save 100,000 lives. 100,000 lives in 18 months by June 14th, 2006. And he was met by stunned silence. Like, how are you going to do that? He had, I like using hand gestures. Have you noticed? He had six. I can't figure out how to use my camera. 6 specific steps, and only 6. Preventing ventilator-acquired pneumonia by simply raising the head of the bed to 30 to 45 degrees, preventing secretions from going down into the airway. He wanted to create rapid response teams in all hospitals. He wanted to use a standardized treatment for all myocardial infarctions, heart attacks, which would include an immediate aspirin, beta blocker, ACE inhibitor, and an admission to cath lab time of less than 60 minutes. He wanted to institute standardized medication reconciliation. When people are admitted to the hospital, he wanted to know what medications they were taking from everybody, and when they were discharged, he wanted a coordinated medication list to go home with. He wanted to prevent central line infections simply by using better sanitary practices, scrubbing the hub. And he wanted to prevent surgical infections by correct and timely antibiotics use all the time. Not just the correct time, but the correct antibiotic. That's it. Is that, in your opinion, is that an overwhelmingly complex plan? It really isn't. He unfroze the group by announcing it publicly and explaining the need for change, the 100,000 reasons for change. He convinced hospitals to join in to reduce their death rate. Think of that phrase. Medication errors equals death rate. That gets people moving. And when a hospital joined in, when they publicly acknowledged and joined, they received community and industry recognition saying, this hospital is now with us. So if this hospital is now with us, is that hospital across the other side of the city, because they're going to reduce their death rate. What do you think happened in your hospital? Yeah, they wanted to join too because they don't want to be known as the hospital that doesn't care about their death rate. So he unfroze previous practices by explaining why and encouraging involvement, making it very easy to join. He moved them to new practices by creating champions for each of these 6 steps. These champions included doctors, nurses, respiratory therapists, and administrators. There weren't a lot of champions, but there were a few, and the champions went around and persuaded new people to buy in to this new practice, which is really just best practices. And every time a new person joined, they were able to use that new person as peer pressure to get one more person to join. So that one person, that one champion, was soon able to have two champions with him, and then 4, and then an entire department, and then an entire wing. And eventually it snowballed very rapidly because they discovered these new practices worked. And they weren't hard to do. When the hospitals began to experience decreased mortality, they all refroze that new pattern. And on June 14th, 2006, he announced that nationwide an estimated 122,300 lives were saved just using those 6 evidence-based steps. That's why using evidence-based to drive our practice is so critical, because it is proven to work. It's proven to be duplicatable across specializations and across the country. So that's why we want you to focus on evidence and remember that change cycle. We'll talk about that again a little bit later this lecture. Now there's continuous quality improvement organizations, quality assurance it's sometimes called, or total quality management. It could be risk management. The latest thing is called 6 Sigma. 6 Sigma comes from the automotive industry. And they believe in reducing errors to 6 decimal places after the decimal point, like 1 in 100,000. That's their goal. It redesigns structure and processes, and it improves. It's looking for an improved outcome of greater than 95% of the problems. To do that, you need to move away from the culture of blame. And what's the culture of blame? The culture of blame is simply saying, well, I'm doing it because they're doing it, or I'm doing it because that's what I was told, or, well, nobody told me otherwise. The culture of blame says that it's never my fault. It's always somebody else's fault. It doesn't matter who's at fault. It really doesn't. It doesn't matter if you were taught that way. If there's a better way, you need to learn the new way. It doesn't matter if you always did it that way. Sometimes there's better ways. So what's the nurse's role in all this? Now, when they interviewed doctors, they considered nurses, only 8% of doctors felt that nurses were decision makers. Yet most errors were considered to be nursing errors. So as nurses, we can't make decisions, yet we're the ones making the errors. And only 10% of clinicians actually confront a quality concern when they see it. But of those 10% that do, they're the ones that see improvement. So doctors don't think that we make decisions, yet we're responsible for the mistakes. And when we address mistakes, when we see problems, we improve problems. Does that explain why your clinical instructor can be really hard on you sometimes? We want to improve your habits, your practices. We want to create strong, excellent nurses. And the only way we do that is by pointing out where you have a weakness and how you can improve that weakness. It's never fun to be on the receiving end of that discussion. I will be the first to admit that. But that's why we do it, because the only way we can improve the profession is by improving everybody in the profession, and that means students as well as current nurses. So what's the nurse's role in quality assurance, quality improvement? You need to be aware of the benchmarks. You need to help evaluate causes of poor outcomes. You need to be the eyes catching those poor outcomes. And you can help develop an improvement process. Suppose it's something as minor as washing your hands. In the hospitals that I work in, for my clinicals, we have alcohol dispensers inside every room. So there's no excuse. Now that's at one hospital. At another hospital, there are alcohol dispensers outside every room. Which do you think is more effective, outside or inside? Inside. Because outside the room, you're still washing your hands, you're still sanitizing them. But there's no feedback from the patient. See, when there's a dispenser inside the room and the patient can hear it be activated every time somebody walks in and walks out, if you walk in and don't use it, they know. And if they know, some of them will tell you about it. And if they don't tell you about it, they might tell other people about it. So if you're working in a facility that does not have alcohol dispensers inside the room, that could be something you could suggest to increase the proper hand washing. It's really small. You're moving the dispenser, but it'll have greater impact. Now there's structure, processes, and outcomes. And these are indicators and standards that we use to identify where we're going to put our efforts. Are we going to attack the structure, the process, or change the anticipated outcome? This is important. Because when you understand the structure, process, outcome, you will be able to target your actions on one thing. If you want to improve hand washing, you could say, we're going to improve hand washing. It's pretty broad. But how about you say, we're going to improve hand washing by moving the alcohol dispensers inside the rooms. That's a concrete, single step that you're doing. But is that a structure, a process, or an outcome? Well, let me define these three things, and then I'll give you the answer. Or maybe you'll already know the answer. Structure is the stuff, the staff, the budget, the supplies, the equipment, the technology, your computer systems, the documents. It's the stuff you can see and touch. An alcohol dispenser is a structure. The processes is what we do. So using that alcohol dispenser is a process. The outcome is the end result. So, and the end result here would be that you have sanitized hands, you wash in and wash out. So the outcome is a sanitary interaction with that patient. When you move that alcohol dispenser inside the room, are you changing the structure, the process, or the outcome? Well, the outcome is the same, right? You still have a sanitary interaction with the patient. The process is unchanged. You're still washing in and washing out. You're moving the structure. You're changing the structure, the thing, the stuff that's on the wall. You're moving it to where it's going to be more effective. When you look at preventing central line infections, and you go out and you get your central line kit, that kit is the structure. The process is scrubbing the hub correctly and scrubbing around the insertion site correctly. The outcome is reduced central line infections. Structure is something that you can see or touch. Processes is the action. Outcome is what are you looking for? Structure, process, outcome. You got to know those three components if you really want to change something. Let's say I want to improve grades in my class. I want to have more A's and B's in my class. That's a nice outcome, isn't it? Especially if you're in the class. Is that structure, process, or outcome? Outcome. That's the end result. What would the structure be? What would the structure be if I wanted to improve grades in my class? Textbook, lectures, test forms. Actually, a lecture would not be a structure. No. The information in the lecture would be structure, the data. But how the lecture is presented is process. Is it face-to-face? Is it video like this? Is it a voiceover PowerPoint? Or is it just written out information? That's the process. So if I wanted to improve grades in this class, where would be the best way of addressing it? Would it be to get a better textbook? Possibly. Different lecture notes? Sure. Write a different test? Maybe. Or is it the process that we have to change? Should I switch to only face-to-face or only video or face-to-face and video? I don't know. It's one of those situations where there are many things to do. What would be the best way of addressing it? Should I buy a new textbook, change my tests, create a new lecture, and create different formats of getting the information? Well, I could. And then when I get good results, which one of those four things were the actual good thing? Was it the new text or was it the different format? Change one thing at a time. That's always the best way to make a change when you have time, is to make one change, evaluate the results, and decide, good enough or can we do better? So, structure, process, outcome. Very important information. Key outcome indicators. So, the key outcomes are going to be nurse-sensitive outcomes. They're going to be quality indicators. So it could be infection rates, injury rates. Patient satisfaction is an outcome, and nurses have a huge impact on patient satisfaction. Sorry about that. How can a nurse improve patient satisfaction? How can you improve patient satisfaction? Simply being there more often. Not necessarily longer, but more often. Stop in. A lot of times, most facilities now have a minimum of once an hour eyes on the patient. So that's the minimum, once an hour. If you have a chance, pop in more often. It doesn't take long. Poke your head in and ask the simple question, is there anything I can do for you right now? Otherwise, I'll be back in 45 minutes. One question. If they say no, you're good to go. If they say yes, I need, then you've answered it. But guess what? You've also probably prevented a call light from going on. So that is going to make everybody happier. Now, when you go to the learning plan in Angel, you will see a link to Medicare nursing home comparisons, and there's another one for hospitals. I want you to go out there and in your hometown, wherever you happen to live, go out there and pick 2 or 3 nursing homes and 2 or 3 hospitals in your area and compare the results from side to side. You will be amazed at the differences that you will see. It sometimes can be shocking and sometimes can be pleasingly surprising. But I want you to go out there and do that. To be honest, there won't be a question comparing hospitals, but understanding outcomes will be something that you might see again. Okay, so go out there and take a look at that. It doesn't take very long. Go to the learning plan in Angel. Click on those. They're active links. It'll take you out to the Medicare nursing home comparison, the Medicare hospital comparison pages, and then just choose your city and state and pick the facilities. Now, Joint Commission also monitors patient safety goals in hospitals. It's updated annually. It looks at structures and processes. Obviously, the safety goal is the outcome, so it's only going to focus on structures and processes. Sometimes places will address outcomes. They will change benchmark standards up or down, depending upon which is appropriate. Obviously, reducing a benchmark makes it easier to achieve, but that's kind of gaming the system, in my opinion. If you make, I could make everybody get an A if I make 80% as an A. So y'all get A's, but does that mean anything? In my opinion, no. So I'm not doing that. The grading scale is as it is in the syllabus, but that can be done. JCO, Joint Commission, focuses on structures and processes. They look at concrete things that should be done and are not being done, and what has to take place. And again, in Angel, there's a link that goes out to the Patient Safety National Patient Safety Guidelines. So go out there and take a look at that. We're about 27 minutes into the lecture. I'm going to stop right now and pick it up with Part B. I like to break these lectures into about half-hour segments, as you've noticed. I think they're a little bit easier for everybody to listen to. So, stopping now, we'll come back right away, looking at monitoring quality and standards and goals.